My name is Nicole Dunn, and today I'm going to be talking about nurses' role in chest tube management. So first I'm going to be talking about the anatomy of the thoracic cavity. Specifically, I'm going to be talking about the structures relevant to chest tubes. So first here we have the diaphragm, which is a muscle involved in the ventilation process. Next we have the lung, and then surrounding the lung we have the pleural cavity. Closest to the lung we have the visceral pleura, and then the next layer we have is the parietal pleura. In between these two layers is the pleural cavity, and this is where the chest tube will go. To understand chest tubes, you need to understand the three pressures involved in ventilation. So there's the atmospheric pressure, which is the pressure of the air that you breathe, the intrapulmonary pressure, which is the pressure inside of the lung, and then the intrapleural pressure, which is the pressure in the pleural cavity that's surrounding the lung. This intrapleural pressure is always about 3 to 4 millimeters of mercury lower than the intrapulmonary pressure, so that pressure inside of your lung, and this negative pressure prevents the lung from collapsing. So we need to understand that the atmospheric pressure and the intrapulmonary pressure always have a gradient between them. So the atmospheric pressure is either higher than the intrapulmonary pressure, which causes air to move into the lung, or the intrapulmonary pressure is higher than the atmospheric pressure, which causes the air to leave the lung. And that intrapleural pressure is always lower than that intrapulmonary pressure, and this prevents the lung from collapsing. So if something was to cause that intrapleural pressure to be the same as the pressure in the lung or the same as the atmospheric pressure, this would cause the lung to collapse. So what is a chest tube? It's also known as a thoracostomy tube. It's a tube inserted between those pleural layers to remove fluid or air, and it goes into a chest drainage unit, also known as a drainage canister. So these tubes are placed by doctors. Here in this image you can see the chest tube inserted in the patient, and then it goes down into the drainage canister. The second and third image show the chest drainage unit close up. So here you can see the drainage collection chamber, and this holds all of the fluids from the patient, or the air from the patient. The next chamber here we see the water seal chamber, and this holds about 2 centimeters of water and acts as a one-way valve from preventing air to re-enter the pleural cavity. And then this chamber can also be used as an air leak monitor. This will show bubbling if there's any leaks along the chest tube or in the chest drainage unit, and it can also show bubbles indicating that air is leaving the pleural cavity from a patient who has a pneumothorax. The last chamber we have here is the suction control chamber. This is the part that's connected to the wall suction, and this helps to remove air or water from the pleural space. So what are chests used for? They're used for patients who have a pneumothorax, which is air around the lung, a hemothorax, which is blood around the lung, empyema, which is purulent fluid around the lung, hemopneumothorax, so air and blood around the lung, pleural effusion, just fluid around the lung, and a chylothorax, which is lymphatic fluid around the lung, and it can also be used to deliver medications such as chemotherapy for individuals who have lung cancer. So what is the nurse's role in all of this? They're involved in the preparation of equipment, management of the equipment, assessment of the patient, providing comfort to the patient, administering medications, and reporting and monitoring adverse events, and providing updates to the most responsible physician. So preparation of the equipment, this also involves preparation of the patient, so having the patient in that sitting or lying position with the affected side up, cleansing the area. The doctor may also want to do this, it just depends on their preferences, and then actually getting the equipment available for the physician. So oftentimes this is available in a kit. So this kit will have a chest tube with probably like a standard size chest tube. They may need a different one depending on the patient size. They will also have the chest drainage unit, a scalpel, the necessary surgical instruments to assist in sharp and blunt dissection, so to get down into that pleural cavity, suture instruments to secure the chest tube to prevent it from moving, gauze, sterile drapes, antiseptic, sterile gloves, and possibly a Heimlich chest drain valve, which is this right here. These are used for patients who have a small pneumothorax that will use this instead, and it will just have a drainage collection bag on the end to collect any fluids or air. Lastly, we'll have some lidocaine for a local anesthetic, and then a dressing. We should also keep an occlusive dressing like a gauze soaked in Vaseline bandage next to the bedside in case the chest tube is removed by accident. This can be used to seal up that insertion site. So the nurse will also be involved in the management of the equipment, so ensuring patency of the tubing. When doing so, ensure you do not clamp the tubing. This can actually cause a tension pneumothorax. Changing of the dressing around the insertion site when soiled. This doesn't often occur, but the doctor may order it, and then the nurse would be responsible for changing it. Monitoring the amount of drainage in the container. So at the beginning of your shift, you would mark off where the drainage is, and then monitor the hourly output. We do not like to see more than 100 cc's per hour. Anything more would have to be reported to the physician. Monitoring titling of the patient pressure float ball. So in this section here, you'll see a little ball, and when the patient is not hooked up to suction, you will see this ball moving up and down. You may not see the ball moving up and down, and this would indicate that the lung has inflated. If the patient is hooked up to suction, the ball will not be moving up and down. We'll also be looking for bubbling in the water seal chamber. You'll see this if there's any sort of leak along the tubing or in the drainage canister. You may also see it if the patient has a pneumothorax. Second last, we'll ensure the dry suction regulator is set to the right setting, usually at 20, but it depends on the physician. Lastly, we will be looking at the orange suction bellows to see if they're expanded to the triangle. This would indicate that the machine is getting the suction from the wall. If the physician didn't order it, then we'll be looking to see that the bellows are not expanded. So what systems would we be assessing? The cardiovascular system. So like I said before, we would be assessing these systems because a tension pneumothorax can occur, and when a tension pneumothorax occurs, it can put pressure on the great vessels and disrupt the cardiovascular system. So we'll be listening to S1, S2, checking the blood pressure, the pulses to ensure adequate perfusion. We'll be assessing the respiratory system, respiratory rate, ensure adequate ventilation, that sort of stuff. And then we'd also be assessing the integumentary system, so surrounding area, looking for subcutaneous emphysema. This may occur, which is just some air under the skin. We also will be checking the insertion site, see if there's any signs of infection. Next, we would be providing patient comfort. So you'd be looking at the pain level for the patient, assessing them using the pain scale, providing them with pharmacological and non-pharmacological interventions as needed, helping with ADLs so the patient can't move very much. We need to help with washing the patient up, helping them to avoid in stool, that sort of stuff, helping answering any kind of questions, providing education, and then also pointing them to the resources for things like spiritual support. We also will be responsible for administering medication. So antibiotics and pain medications are the two main things that we would be administering. Antibiotics are usually used on a prophylaxis basis, as we are doing an invasive procedure. They're often ordered when the tube is inserted. Additionally, we would be using pain medications. As I said, it's an invasive procedure. This can be quite painful to the patient, so we would be administering that. And then lastly, we may be administering fluids. So individuals with a pleural effusion or a hemothorax will be losing fluid, and we want to ensure that we maintain the fluid balance. So another job of the nurse would be monitoring for an adverse events and reporting these to the physician. Things like infection, so we'd be looking for the signs and symptoms of infection. Pneumonia can occur since the patient will be sitting still and in bed. Pneumonia can occur. To prevent this, we want to do those deep breathing exercises, incentive spirometer, that kind of stuff. Frozen shoulder. This can occur since the patient is sitting still. We want to ensure that they're doing those arm exercises to prevent this. And then lastly, we want to be looking for signs and symptoms of injury to organs upon insertion. So the lungs, heart, liver, and spleen are often the organs that may be affected when inserting the tube. So in conclusion, we discussed the anatomy of the thoracic cavity, the pressures involved in ventilation, what a chest tube is, what chest tubes are used for, and what the nurse's role is. So preparation of the equipment, management of the equipment, patient assessment, patient comfort, administration of medications, and reporting adverse events and providing updates to the most responsible physician. Here's my references slide. Thank you so much for listening.